Hey guys, so for my clinical presentation today, we'll be discussing colorectal cancer. Just to begin, the images you see on the screen here on the left are normal colon cells, whereas on the right is an image of an adenocarcinoma or colorectal cancer. So you can see kind of the difference between those two. We can go ahead and get right into the presentation. For some context, first I think it's important to discuss the anatomy of the digestive tract and colon anatomy. You can see the entirety of the digestive tract on the left, with the colon highlighted in the red box. On the right is an image of just the colon. The right side of the colon image there is actually what's called the left colon, left portion of the colon, or the descending colon. And on the left side of the image is considered the right side of the colon, or the ascending colon. This is important because depending on where a colorectal cancer is located within the colon, different symptoms can present, and it's important for surgery options and for treatment options to know exactly where the cancer is located within the colon. So some sort of fast facts about colorectal cancer. It's the third most prominent cancer worldwide, behind breast and lung cancer, and it is the second leading cause of cancer death. This is mostly because it's pretty prevalent amongst both men and women, whereas breast is, much more prevalent amongst women, and prostate cancer is much more prevalent amongst men. There are multiple risk factors that make colorectal cancer more probable within patients. Colorectal cancer is much more prominent amongst older people, as it takes a little while to develop. A sedentary lifestyle is also conducive to colorectal cancer, so exercise can help a lot as a preventative measure. Family history plays a large contributive part, as well as the presence of irritable bowel disease, either Crohn's disease or ulcerative colitis. Those are two diseases that cause immune responses in the colon to your own colon cells, and have a wide array of symptoms. But having Crohn's or UC are huge risk factors in terms of the prominence of colorectal cancer. So the one good thing about colorectal cancer is it is relatively easy to detect in comparison with other cancer types. I'm sure most of you have heard of a colonoscopy. It's a regular procedure that is recommended at the age of 45, and every 10 years after, assuming a clean screen. A colonoscopy is simply just where a camera is put through the entirety of the colon, and you're screened for any polyps, which I'll talk about in the next slide, or for the presence of any cancers within the colon. There are a couple alternatives to a colonoscopy, although they have some kind of pros and cons. There are the FOBT FIT test, which is a stool sample, effectively. You send your stool in, they can test for the presence of certain indicators of cancer or of polyps, although they aren't as accurate. And in comparison to a colonoscopy, they can't do anything about a polyp with a stool test. If you get a colonoscopy and a polyp is located, it can be resected and sent in for a biopsy to see if it's benign or malignant. There are digital screens possible as well, but again, not as good as a colonoscopy. So I mentioned in the last slide, polyp. These are just small growths within the colon. They can be precancerous or cancerous. There are two kind of main types of polyps, pedunculated and sessile. Pedunculated, as you can see on the top image on the right, is a polyp attached to sort of a stalk, whereas a sessile polyp is a flat polyp within the colon. So precancerous polyps are referred to as adenomas. They're relatively benign. If they're located through a colonoscopy, they can be resected and sent in for a biopsy. If they're cancerous, however, they're referred to as an adenocarcinoma, which is colorectal cancer. Polyps are very common. They're present in 30 to 50% of all people. So if you go in for a colonoscopy and a polyp is located, it's not a huge deal. You just get it biopsied, and only about 1% become cancer. You can see on the bottom right image, kind of the growth cycle of a cancerous polyp, and how it invades the lining of the colon. So this is why colonoscopies are so important, because if a polyp is found and resected early, it can really help in preventative measures against colorectal cancer. Whereas if you don't get a colonoscopy for a while, a polyp can develop into an adenocarcinoma relatively easily. So in terms of prognosis for colorectal cancer, for non-metastatic patients, people with stage 1, 2, or 3 colorectal cancer, the prognosis is generally pretty good. I know that image isn't the best, but you can see for stage 1, it's about a 90% 5-year survival, 60% for stage 2, and about the same for stage 3. There are a bunch of treatment options for non-metastatic CRC. I'll discuss those in the following 2 slides. But for metastatic patients, the prognosis is definitely a lot less good, as with most cancer types. There's 20 to 30% of metastatic patients do have some surgical options, which definitely help the prognosis a lot. But for people who aren't candidates for surgery, the prognosis is generally not great, about a 10% 5-year survival. Really, so you can do some chemotherapy, but it's merely just extending life by a few months in terms of the options for non-metastatic patients. So in terms of treatment options for colorectal cancer, for non-metastatic patients, surgery is a really common option. You can get total or partial resections of the colon, meaning removal of certain sections of the colon. So you can see on the right an image of a partial bowel resection, which is just where a portion of the bowel is removed, and basically the 2 ends are sewn back together to kind of complete the colon chain, if that makes sense. About 80% of non-metastatic patients are candidates for this, which is really good, because it's a great option for these cancer patients. Along with portions of the colon, surrounding lymph nodes are often removed just as a preventative measure for metastases throughout the body. After resection, many patients do choose to get chemotherapy as sort of like a preventative measure for metastases in the body, but also just to like make sure all the cancer cells are dead within the colon. So the chemotherapy options, there are a couple different ones. FOLFOX, which I know we've discussed before in other clinical presentations, is a really good option for colorectal cancer patients. The main component of FOLFOX is 5-FU, which I know we've heard about for, I believe, kidney cancer and breast cancer. That's used in conjunction with 2 other drugs, as well as IFL, which is used more so for metastatic patients. That's again using 5-FU in conjunction with a few other drugs. These are both great options for non-metastatic patients, but IFL, especially for metastatic patients, has shown to increase average survival by 14 months, which might not sound like a lot, but is actually a really long time in terms of survival after metastatic diagnosis. So great options, and obviously new ones are being developed even now. So the case study for colorectal cancer is a woman named Mary Mapson. She had a history of hypertension, which is high blood pressure, and hypothyroidism, which is an underactive thyroid. Just for some context, the thyroid controls metabolism in the body. So an underactive thyroid would indicate that Mary was probably, or had a greater chance of being a bit overweight, would have trouble metabolizing food. So again, keep in mind sedentary lifestyle and weight are risk factors for colorectal cancer. She came in to see her doctor because she had an unintentional weight loss of about 20 pounds, which is a lot. She was fatigued and had blood in her stool, so a lot of kind of concerning things. She had rejected preventative screening colonoscopies in the past, so she had not received a colonoscopy before. When she came in and reported these symptoms, she was given a colonoscopy, and they found multiple tubular adenomas, or benign polyps, as well as a large adenocarcinoma in her colon. So they obviously diagnosed her with colorectal cancer, and they did a bunch of additional screening and found that it had metastasized to her liver. And I haven't mentioned this before, but the liver is kind of the most common site of metastases with colorectal cancer. You can get surgery to remove lobes of the liver that have metastatic cancer in them. However, Mary was unfortunately not a candidate for this. So really her only treatment options are palliative chemotherapy. So she underwent the FOLFOX treatment, which I mentioned before, as well as bevacizumab, which I know Father Nick mentioned in the lecture yesterday in angiogenesis. It's a VEGF inhibitor. At the time of writing of the case study being written, Mary was still alive. However, she does have metastatic colorectal cancer, so the prognosis isn't typically great. Really, the take-home message from her case study is how important regular screening is with colonoscopies. Obviously, if something is found in a colonoscopy, they have you come in for more regular screening, probably every 5 years or so. But again, for age 45 and up, it is really recommended you go in every 10 years for a colonoscopy, and it is a great just kind of preventative measure for the cancer. So that's all I have for today. Thank you guys so much.